Good evening to all the respected faculty and delegates present here. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar organized by AMOGS Medical Disorders Committee with Ranchi OBGYN Society. So let us start the webinar with lightning of the lamp and blessings of the God.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं
I would like to invite the MOC of today's webinar, Dr. Archana Kumari ma'am. Ma'am is currently the Secretary of Ranchi OBGYN Society from 2023 to 25 and Founder Secretary of IFS Jharkhand chapter and also the elected executive member of National ISOPA from 24 to 26. And ma'am has received numerous awards and also has 30 publications and 7 chapters in book. So I welcome you, ma'am, and I hand over the session to you.
Thank you so much, Saiti, for that kind introduction. So, on behalf of the Ranchi OBGYN Society, being the secretary, it's my privilege to associate with Sneha Madam, that is All Maharashtra OBGYN Society's Medical Disorder Committee, for today's webinar. Just to carry forward the program, I would like to invite and formally introduce Sneha Buyar Madam. Well, Madam, I have been closely associated with her since last 1 to 2 years, and I know how commendable work she has done as a Foxy Breast Committee chairperson in 1921, and she's currently, of course, the chair of the Medical Disorder Committee of AMOGS. Madam has also been the governing council member of ICOG in 21-22, and she's also the member of CIFOG working group. She has been the founder president of Vidarbha ISOPA, peer reviewer of Jogi Journal, and she has so many accolades to her credit. Like she's received recently the MS Signature Award for phenomenal leadership. She's also the recipient of Dr. Durusa Distinguished Community Service National Individual Award, Anandbai Joshi State Award, and so many. She has 31 years of experience in the field of OBGYN. She has delivered so many talks, more than 30 chapters. So, Madam, I welcome you to this webinar, and please carry forward with.
Thank you so much. I would request our chief guest today just to put on your video. We want to welcome you, Dr. Jaideep. A very good evening, respected seniors and dear friends. At the outset, I welcome all the dignitaries for this program, especially Dr. Jaideep Tang, President-elect of Foxy, as a chief guest for today's program, and Madam Usha Nath as the guest of honor. Respected President AMOGS, Dr. Rajendra Singh Pardesi, Madam Sujata Darvi, the Secretary of AMOGS, Madam Nandita Parshidkar, immediate past President, and dear friend Dr. Kiran Kurtakoti as President-elect of AMOGS. Our seasoned orators for today's program, both my favorite Dr. Kuldeep Singh and Dr. Girija Wagh, my dear friends, Dr. Shashibala Singh, President of Ranchi, and Dr. Archana Singh, the Secretary, all the esteemed faculties, panelists, chairpersons, I welcome all of you for today's program. My respect and regards to all of you. As chairperson of Medical Disorders Committee of AMOGS, I have tried to reach almost every society all over India and tried to cover the entire spectrum of medical disorders. Being a hardcore and hardworking obstetrician, of course, I'm trying to incorporate my practical experience as well for the variety of cases. And I wish to deliver the message that agreed obstetrics is an unpredictable, unprecedented things do happen, but majority of the times we can, predict, and of course, we can prevent certain things. But if at all we have to face it, we should be prepared for it. So we have excellent Maestro, Sono School, Dr. Kuldeep Singh, revered teacher, Dr. Girija Wagh, to speak on the important topics. And of course, I'm moderating the panel on hyperglycemia and pregnancy. So with this, I just want to thank the Ranchi Society and of course, all the faculties. And it's my proud privilege to have Dr. Jaideep Tang as the chief guest for today's program. And I have been closely associated with Dr. Jaideep and has worked under him as when he was the Secretary General of FOXI. Of course, he's got very highly decorated CV and such an illustrious person and orator, all of you know. I'm not going to go into the details of this, just President FOXI elect and chief guest for today's function. And of course, we would like to listen to your precious words, Dr. Jaideep. Over to you for your valuable advice for us.
Thank you very much, Neha, for inviting me for this webinar. I hope I'm audible and I can be seen.
Yes,
sir. Thank you. It is indeed a delight to be in this webinar, particularly with the Ranchi Society and the AMOGS Medical Disorders Committee. I have visited Ranchi several times. Unfortunately, I missed visiting it for its last big conference, but I look forward to being in Ranchi again soon. Thank you very much to everybody from the Ranchi Society, President Dr. Sashibala Singh, Secretary Dr. Archana Kumari, and of course it is a privilege to share the dais with Dr. Ushanath Madam, someone we all know and respect, who is the patron of the Ranchi OBGYN Society. And I must also acknowledge the AMOGS office bearers, Pardesi Sir, Nandita, Dr. Sujata, Kiran, and of course Sneha. I've known Sneha for a long time now, and I've always been very impressed with her ability to get the work done. She is extraordinarily sincere, and I think she's set the bar as committee chair for the press committee so high that it's incredible the amount of work you did, Sneha, and I want to wish you all the very best for all your future endeavors. You have really put together a fantastic program today with great speakers. Dr. Kuldeep Singh, someone we have heard so many times. It's always a pleasure to listen to him. Girija, who I'm fortunate will be the vice president next year, along with my presidency in FOXI. And wonderful chairpersons, Dr. Preeti Bala Sahay, Dr. Anjana Jha, Dr. Sashibala Singh, and Dr. Archana. Very important topics they have, particularly the panel on HIP, which is being moderated by you, and as Dr. Suman Sinha, who is the chairperson-elect of our Vaginal Surgeries Committee. It's a new committee, so we are looking forward to great work for Dr. Suman, and Dr. Usha, Dr. Kamal, Dr. Kumari Kadambini, Dr. Minakshi, and Dr. Rupashe. All in all, it's a fantastic program, and it's a privilege and a pleasure to be here, Sneha. Thank you very much again for inviting me.
Thank you so much, Dr. Jaideep, for your precious words, and definitely your blessings will go a long way. Of course, your guidance, I will be always needing for it. Thank you so much once again. Now, it's my privilege to introduce the guest of honor for today's program, Madam Ushanath, who is the patron of Ranchi Society. And Madam, such a senior, experienced person, and I'm sure her expertise and experience is very valuable for not only for Ranchi Society, but for all of us. Madam has, she has stayed in UK, worked for so long, and even after coming back, she is serving the society. Very inspiring, Madam, and we would like to listen to your precious words as well, Madam. Please bless us. Thank you so much, and over to you, Madam.
Thank you very much, Sneha, for inviting me. I'm really honored that I'm here as a guest of honor. And good evening to everybody. Dr. Tank sharing the platform with Dr. Jaideep Tank is in itself a very appreciative and very, very honored status for me because he is so, I can't say the word, but he is very knowledgeable, and I always enjoyed his speech or any talk or anything, always. And here, Ranchi Obstetric and Gynae Society, I see, has grown up so much and is having so much of association with the Fox, with the center, and is having the attention of Foxy, all the people from there, they actually recognize us and we are having some recognition. So I congratulate all my Roxian as well. And thank you very much. This topic which we are going to talk about is ultrasound in medical disorder of pregnancy. I just recently have encountered one such case. One of my patients, she fell pregnant, and when in ultrasound, it was found that the baby doesn't have the nose. The nose bone was absent. And I was surprised because this was a second pregnancy. The first pregnancy, very good, although I did her cesarean section for that. And then we did all the tests and the quadruple test that was positive. So ultimately, we had to abort the pregnancy. So in the sense that this is really a very helpful tool in the hand of obstetrician. So I'm waiting to hear furthermore what else I can learn here. So thank you very much, and good luck to all of them here. Thank you.
Thank you so much, madam, for your words of wisdom. And now, Dr. Rajendra Singh Pardesi, the president of AMOGS, he's busy with some emergency. So, sir is unable to join, I think, for the first time for our program. But because we obstetricians are, it is unpredictable, I just said. So, we would like to go ahead with the program. And I would invite Madam Sujata Darvi, the secretary of AMOGS, and madam is such a humble person, inclusive of everybody, and she is associated with so many hospitals and very hard working obstetrician clinician, I would say. So we would like to listen to you, Madam Sujata Darvi. Over to you.
Thank you, Sneha, for a very kind introduction. At an outset, as a secretary of AMOGS, I would like to welcome one and all for this webinar conducted by AMOGS Medical Disorder Committee, headed by Dr. Sneha Buyar, along with Ranchi Obstetrics and Gynae Society, headed by Dr. Shashibala Singh as a president and Archana Kumari as a secretary. I would like to also express gratitude to our AMOGS president, Dr. Rajendra Singh Pardesi, and Dr. Nandita Palshetkar, past president, and Kiran Kurtakoti as an incoming president, for always guiding AMOGSians so far as academic activities are concerned. I would like to acknowledge the words of wisdom which were given by our incoming Foxy president, Dr. Jaideep Tang, and we would now hear him more, and we will be able to see him more in the next year once he takes over as a Foxy president. And also would like to acknowledge the words of wisdom given by our guest of honor, Dr. Usha Nath, who is a patron of Ranchi OBGYN Society. And I'm sure today's topics are being covered by speakers who are very well known in their respective subjects. They include jaundice in pregnancy, sonography, and of course, hyperglycemia in pregnancy. Panel discussion going to be conducted by Dr. Sneha Buyar. And I wish them all the best wishes and good luck for today's webinar and their future endeavor in Foxy. Thank you, Sneha, so much.
Thank you so much, madam. And once again, I declared that the inauguration has been done for this, and I thank all the respected dignitaries, including the AMOGS office bearers, Dr. Pardesi sir, Madam Sujata Darvi, the immediate past president, Dr. Nandita Palshetkar, and of course the president-elect, Dr. Kiran Kurtakoti, chief guest for today's program, Dr. Jaideep Tang, and guest of honor, Madam Usha Nath. Thank you so much, and I hand over the forum to Dr. Archana Kumari now for further proceedings. Over to you, Dr. Archana. Thank you so much.
Thank you, ma'am. So We'll start with the scientific session, and the first topic is role of ultrasound in medical disorders of pregnancy. For this, may I invite Dr. Preeti Bala Sahai ma'am and Dr. Anjana Jha as chairperson. It's my privilege to introduce my mentor, Dr. Preeti Bala Sahai, as chairperson today. I have been closely associated with her for past maybe 18 years. I had been the resident and assistant professor in her units. She was the ex-HOD of RIMS OBGYN department. She was also the chief coordinator of emergency obstetric care of Jharkhand, a profoundly skilled surgeon and academician. And she has so many accolades to her credit. So I would also like to introduce the next chairperson, Dr. Anjana Jha, who is a close friend of mine. She is currently the secretary of ISOPA Ranchi chapter. She has been the vice president secretary of ROGS as well, and she was the ex-GMS of CCL Coal India. And of course, she received award while working in Coal India. Such a humble personality. So over to you, chairpersons. May I request Dr. Anjana Jha to introduce our speaker, Dr. Kuldeep Singh.
Anjana?
Anjana Di?
Yeah, you need to unmute, please.
Yeah,
Yeah.
Good evening, everyone. First of all, my pranam to my respected and teacher, Dr. Preeti Bala Sahai, who is my co-chair. I am very fortunate to chair this session, and I have been given the pleasant task of introducing Dr. Kuldeep Singh sir. He is master trainer in his field of ultrasound, which he is so passionate about. He practices ultrasound in New Delhi and is known for his skills in ultrasound in OBGYN and infertility. He has more than 600 talks in national and international platforms. He has been invited to share his academic experiences in Japan, France, Spain, Italy, Belgrade, Dubai, Seoul, Dhaka, Kathmandu, Philadelphia, and Singapore. He has received 4 awards and 3 gold medals in the field of ultrasound. He has authored 16 books on ultrasound in OBGYN and infertility. His books have been translated into Spanish, Chinese, and Portuguese. He was awarded the Imaging Science Award in the AICOG in New Delhi. He is successfully running Sono School, which organizes various training programs in ultrasound in OBGYN and infertility. Ultrasound is the window through which we can see inside the uterus and look at the fetus. Ultrasound provides us extensive information and has also improved patient care. I'm sure today we have lots of academy, and now I request Kuldeep Singh sir to proceed for his talk.
I hope you can all hear me. Thank you, Dr. Anjana. Thank you so much.
I invite you.
Thank you, Preeti Bala ma'am. Thank you so much. I'd like to thank Dr. Usha Nath ma'am, Dr. Jaideep, thanks sir. Dr. Sneha, always a pleasure. Thank you so much. Team ROGS, Dr. Suman, Dr. Archana Kumari, Dr. Shashi Bala, thank you so much. Dr. Girjava, again, we always meet here in the webinars or the conferences. I'm going to start sharing my screen, and I hope all of you can see my slides as well. Let me just start sharing it. Are you all able to see the screen?
Yes.
Perfect. Ji. So, Dr. Sneha ma'am has wonderfully come up with this, and I thought I really do not know what all am I going to be including in all this. So, but then when I started off reading, so it's always a lovely feeling to read about these things. So I'm going to be talking on ultrasound in medical disorders in pregnancy. The many of you who are a part of Sono School, what we need to know about is the medical disorders may exist prior to pregnancy, or they can manifest themselves for the first time during pregnancy. That's a long list over there. I'm not going to be discussing too many details about each and every, but I'm just going to be touching on by a slide or two so that we understand whenever we're getting into such a scenario as to what all has to be done. We start off with the most commonest of them, and that's diabetes mellitus. You could have a pre-existing one, gestational diabetes, or a pre-diabetic condition. I hope my slides are moving fine and everyone can hear me clearly, Ji.
Yes,
If there's any
yes.
problem, do let me know.
No, no.
What
It
we
is
really need to be
very
doing
clear
whenever we're looking
slide.
at such a condition is we need to be establishing the gestational age. We need to be looking for congenital malformations, looking for the fetal growth, assessing the Leica amnii, and when needed to do the color Doppler studies. The moment we need to be establishing the gestational age, we need to be doing it in a proper way at a proper time so that we can evaluate growth later. There's no point doing a scan at 28 weeks or 32 weeks. It's really not going to help. And then whenever we require to be interpreting our double markers, quad markers, or anything, we need to be looking at definite gestational age. Might be we need to be timing the amniocentesis and we need to time the delivery. Now, if you're looking at in the first trimester, I think so somebody's mic is on, Ji. If we're looking at the first trimester and we're looking at a crown rump length, if it's within 5 days of the patient's menstrual age, we are going to be conveniently choosing just the menstrual age. The word of caution you always need to remember, you're going to be dating the pregnancy only once in pregnancy. You cannot be changing the EDD every now and then, that in the first scan it was this much, second scan it's this much, third scan it's this much. It just removes whatever we are trying to do. We know a transvaginal scan can visualize a gestational sac as early as 4.5 weeks. We need to be carefully looking in for evaluating the yolk sac, looking at the gestational sac. Nowadays, we started doing a dating scan at around 7 to 8 weeks of pregnancy. Earlier, we might be add up the yolk sac in the embryo measurement, or might be we over or under measure it. So we need to be clearly seeing that the embryo is in the amnion, the yolk sac is in the chorionic cavity, and measure the CRL or the crown rump length. Whenever you're doing it in the NT scan, you need to have it in a proper zoomed manner where the fetus is occupying 60 to 98% of the screen. You need to be clearly defining the crown and the rump points. So it's not only for the NT you need to zoom, even for the crown rump length, you need to zoom it adequately. The second trimester pregnancy, if you're trying to date it, if the patient has come to you for the first time and you're looking at a fetal biometry within 10 days, you are comfortable that yes, we're going to be using the LMP. You need to be adding on the femur length, the head circumference, BPD, and the abdominal circumference to calculate the weight. The moment you cross 20 weeks, or if you're crossing 24, you're just supposed to be looking at the fetal size. Always and always use the same ID for the same patient so that rather than just looking at fetal size every time, you know the fetal growth as well. Growth is when you're charting them and seeing on the centiles, that's how you're going to realize whether are you looking at FGR or are you looking at macrosomia. The moment you're taking a plane, we know it's an axial plane to look in for the BPD. That's the thalamus in the center, cavum, septum, pellucidum anteriorly. Outer to inner is the BPD. Outer to outer, front to back is the OFD. Completely covering this is going to be the head perimeter. Abdominal circumference. Ultrasound is operator dependent. You need to be very patient. You just cannot be saying, I presume things are going to be fine. That's not going to help. In a transverse section of the abdomen, you're not supposed to be looking at the fetal kidneys, only fetal stomach, umbilical vein, and portal sinus. And it has to occupy, or when you're looking at the complete skin needs to be touched in for whenever you're taking the abdominal circumference measurement. Don't look in at the kidneys and the cord insertion in this section. Gallbladder can be seen. There you're looking at that's the liver parenchyma. We're looking at a J shape over there, that's the umbilical vein entering the liver. We're looking at the vertebra, only one rib to be seen. If you're looking at more than one rib, it's an oblique section. And you're looking at the fetal stomach over there. That constitutes a proper section for the abdominal circumference. That is not the kidney, that's the adrenal over there. Stomach, vertebra, rib over there, and that's the J shape. The femur length has to be properly taken so that then we can calculate the weight. In diabetes, we have to be carefully looking in for whether am I looking at SGA, AGA, or an LGA, which is more common, or am I looking at low birth weight, very low birth weight, or extremely low. It's not that in a patient with diabetes is always going to be macrosomia. In some cases, you could be looking at a problematic situation. We need to be looking in for malformations. It has several adverse effects on embryogenesis, and that's why we call it diabetic embryopathy. There are plenty of medical complications that can happen, and diabetic mothers have 2 to 3 times more chances of having a gestation affected with birth defects. You could be looking at neural tube defects, DiGeorge syndrome, Vactal complex, or a Chart syndrome. I'll simplify those things for you. There's a 22%, almost a 1/4 incidence if you're looking at an HbA1c glycosylated more than 8.5 in the first trimester. Usually multisystemic, and you could sometimes, if you're looking at an early growth lag in a mother who has problems, you need to be very watchful. You can be seeing a single umbilical artery. You could be looking at anencephalus, acranias, holoprosencephalus. You need to be watchful. Pathognomic for diabetes is a caudal regression syndrome where you're going to find a stumped in lower portion of the sacrococcygeal spine. In the cardiovascular, you could be looking at an AVSD, you could be looking at a crux abnormality, you could be looking at a TG as well, or a VSD. In the genitourinary or the gastrointestinal, polycystic kidneys, looking at a double bubble as well over there. You just need to be completing your workup so that you do not miss out. You're looking at the abdominal circumference, that's the head perimeter, all on the 50th percentile, but the abdominal perimeter going above the 95th, weight going above the 95th. That's why the HP-AP ratio, because the AP is increasing, this value goes down. In certain cases, you could be looking at an FGR. So you need to be even more watchful because that could be because of vasculopathy. You're looking at the abdominal perimeter going down. Then in looking at maternal hypothyroid states, there could be an early pregnancy failure where you're not looking at a gestational sac, but an increase in the endometrial and subendometrial vascularity. There could be an FGR subsequent to PIH in severe hypothyroid states. You could be looking at a placental abruption over there. There could be lack of fetal movements, no specific increase in malformations, especially the structural ones. Increase of preeclampsia incidence or premature delivery, postpartum depressions and hemorrhages. That's because of the maturation process of the placenta, which can sometimes be seen even in subclinical one. So just be watchful. So appropriate early administered treatment, maintenance of normal level of thyroid minimizes the risk of maternal and fetal complications, makes it possible that we can take it to full term without severe complications. You could be looking at, even in hyperthyroid states, early pregnancy failure. If you're suspecting there could be going in for preterm delivery, be careful of doing a transvaginal and a transabdominal for the cervical lengths. The moment we're looking at cervical lengths going down, the chances of a premature delivery go higher and higher. Some studies have shown an increase in PIH in women with these states. But if you see over here, FGR can be there. PTU has no associated teratogenicity. Methimazole is associated with this, though we cannot diagnose that with the ultrasound. Again, after diabetes, this is also one of the most common conditions, and we're going to speak about it in a little detail. Hypertensive disorders, chronic hypertension, PIH, preeclampsia. While we're doing our uterine artery study, especially for screening, in a high-risk mother, it's going to predict perinatal morbidity and mortality. In a low-risk mother, it predicts a hypertensive disorder. Whenever you're looking at ultrasound as a screening tool for PE, that's to figure out about defective placentation. And we're looking at these placental changes 4 to 7 times in PE than in non-PE pregnancies, and they're associated with an increased resistance to uterine artery flow. If you're looking at, it starts off, might be in the first trimester, there's an increase in the PI value. If you're looking at a transabdominal, if the mean uterine artery PI is more than 2.35, we need to be careful. You start off with the treatments, and in the second trimester anomaly scan, it's still high, it's more than 1.5. They carry the highest risk for adverse pregnancy outcomes. A normal PI does not mean that there are going to be no problems. 95% chances are things are going to be fine, and they have a lowest incidence of adverse outcome. When you're looking at problems in the uterine artery, it is going to identify severe rather than mild preeclampsia and identify severe rather than mild growth restriction. I'm not reading out the whole slide because that's again going to be too much of theory. When you're looking at an increased flow in the uterine artery, when there's an increased impedance, if you see over here, if it's normal, that's the likelihood ratio of FGR, of preeclampsia, of perinatal death. But if it is abnormal, the likelihood ratio goes 5 times for FGR, 10 times for preeclampsia, 3 times for perinatal death. That's how important the uterine arteries are. So a deteriorating fetal status, one of the indications for delivery. Close fetal surveillance. And how do we do a close fetal surveillance? By looking at B mode, so that I can have the biometry, I can have the amniotic fluid index or the deepest vertical pocket. I need to be looking at the Doppler and fetal heart rate monitoring. Fetal deterioration, an indication for delivery in established PE, the fetal status has to be assessed regularly. You need to be looking at fetal growth, BPS biophysical profile, and Doppler studies. And if you see over here, fetal biometry, AFV, uterine arteries, umbilical artery, middle cerebral artery, and CPR. That is, the middle cerebral artery PI divided by the umbilical artery PI is going to be telling us whether things are going to go fine. And the moment the patient presents with these symptoms, headache, abdominal pain, bleeding, or reduced fetal movements, we need to be getting our bells corrected so that we do not wait so that the unnecessary IUD happens. The same test to be considered for women admitted for PE or suspected PE. Now we're looking at mild placental insufficiency. You're looking at either mild problems in the uterine, umbilical, middle cerebral artery, or the CPR is abnormal. You're going to be doing a weekly monitoring, and a labor induction beyond 37 weeks is acceptable, but be careful of the element of distress. You're looking at notching, and the values are high in the uterine artery. Uterine artery in the second trimester, the PI value is high. Or you're looking at, that's normal umbilical artery flow. Reduction in diastolic flow, we know we're looking at start of the trouble. Reduction in diastolic flow. That's a increase in the middle cerebral artery flow, meaning brain sparing is happening. increase in the diastolic flow. Then we're looking at the second step. In this, the umbilical artery is absent and diastolic flow. You need to be monitoring them twice a week. The latest recommendations are 34 weeks. You look at absent and diastolic flow, please deliver. You're looking at 30 weeks, reversal of end-diastolic flow in the umbilical artery, deliver. For early onset FGR, ductus venosus is the end point. For late onset FGRs, the CPR is the end point. There you're looking at absent and diastolic flow. Absent and diastolic flow, and there is brain sparing. You can see how thick the middle cerebral artery is becoming. We're looking at further fetal deterioration. You're looking at reversed and diastolic velocity, ductus venosus forward flow going down. You need to monitor them every 24 to 48 hours, and delivery to be recommended by cesarean section after 30 weeks. Reversal of flow. Reversal of flow. You're looking at reduction in forward flow in the ductus venosus. That's an M sort of a pattern. Then high suspicion of fetal acidosis. You're looking at FHR deceleration. Pulsatile ductus venosus. Monitor 12 to 24 hours and delivery after 26 weeks under steroid treatment and has to be under tertiary care. Deceleration. You're looking at reversal of flow in the ductus venosus. So if you're looking at absent or reversed and diastolic velocity, strongly associated with perinatal morbidity and mortality. If you're looking at a reduction in the PI values, that means more flow going to the brain, we're looking at brain sparing. Or if we're looking at the CPR value going down, a sign of hemodynamic redistribution, and you need to be very watchful. These are some of the endpoints where there's a reversed A wave, means there's a cardiac deterioration associated with a high risk of perinatal mortality and neonatal morbidity as well. Optimum long-term outcomes in FGR with abnormal umbilical artery flow, when you can postpone the delivery just so that you can give their steroids as such. Coming on to another problem in pregnancy, when there is a cardiac problem in the mother. If it's a rheumatic heart disease, good outcome in terms of we're not looking too much for cardiac malformations in the fetus as such. There are no increased chances of otherwise malformations, but the chances of FGR are there. Be watchful. Chances of a preterm delivery could be there as well. Then we have a condition where adults having congenital heart disease, grown-up congenital heart disease, GUCH, is there, and we now know this number is growing because we are able to diagnose them. There are very good cardiac surgeons who are taking care of these patients, and we know half of them are going to be females in terms of when they grow up. So when they're going to be bearing children, we need to be watching out. Higher incidence of fetal and neonatal adverse events. There could be FGR, premature birth, intracranial hemorrhage, and fetal loss. The risk in the heart diseases is highest in women with poor functional, when they're going to have a little bit of cyanosis or having a problem on the left side, which restricts cardiac output. In pregnancy condition, there's plenty of load on the heart because of flow to the placenta, and all these things can get amplified. The IGR or the FGR could be severe, and it's much more in cyanotic heart diseases. Now the risk, if you see over here, if the mother is affected, the chances are quite high with these problems that the fetus also is going to be affected. Not the father, not the sibling as such. Mother is the detrimental factor we need to be watching out for. Now, in terms of using the cardiac drugs, these are the drugs which are relatively safe. And these are the drugs which are definitely not safe. The ACE, warfarin, and the works. We have these various problems that can happen with these: oligoamnios, lack of cranial ossification, and FGRs. You could be looking at risk of skeletal defects, CNS defects over there. Comes on to thromboembolic disease in mama, and you could be looking at a hemorrhage or a clot over there. One needs to be doing a color Doppler study of both the lower limbs, evaluating the iliac veins and the IVC. Mother having asthma, FGR, stillbirths, growth scans and Doppler studies to be done judiciously. The guidance, definitely in CVS, we're no longer going to be waiting for a chodocentesis, has to be figured out in the CVS phase. There could be mamas who could be having problems of seizures, and they're going to cause an increased incidence of preeclampsia, placental abruption, and anomalies, more so because of the medication they're going to be taking. With this, there could be chances of spina bifida, cleft palate, heart defects. The parents are worried, and whoever is doing an ultrasound has to be carefully looking at these. These are the things that one cannot figure out on the ultrasound, but the structural defects, one needs to be following them up. Diphenylhydantoin, again, prenatal and postnatal growth restriction. We could be looking at problems in the face, or there could be microcephaly, hypertaylorism. Integritol or carbamazepine, NTDs, microcephaly, FGRs, cleft lip, gastrointestinal, and renal anomalies. Patients with SLE, there could be RPL problems, PIH, toxemia, FGR, and preterm delivery. Mamas with renal disease, again, you're going to be doing an ultrasound for her kidneys as well to look in for cortical echogenicity, any obstructive urological disease causing a renal disease. And in patients with chronic renal diseases, you're going to be careful about hypertensive disorders, FGR, and preterm deliveries. There are quite a few patients who, because of psychiatric disorders, could be on medication and they do not realize it when they get pregnant. You need to be, in patients who've had this, to be carefully looking in for the right heart problems or looking in for Epstein's anomaly. Last two slides. The outcome for a particular pregnancy depends on the nature of disease, the severity of disease, and the quality of obstetric and medical management. You need to be beginning them before conception, or treatment and counseling has to be done. They need to be evaluated to determine the severity of the disorder and to establish the presence of possible target organ damage. Counseling in medical practice is extremely important. You need to be carefully telling them in written, in oral, that these are the things we need to be careful. And they need to be instructed regarding the importance of early onset of prenatal care. So it's not that a mama has a problem, we're going to be extremely worried about it. We just need to be careful and evaluating them right from the first trimester till the end of pregnancy. And we should all be able to do a good job. Thank you. Thank you so much.
Thank you, Dr. Kuldeep Singh. Your talk was very, very informative about the medical disorders of pregnancy, especially in hypertensive disorders of pregnancy and diabetes mellitus. You have nicely explained when to do. And this in diabetes mellitus, one thing, sometimes there is a sudden demise of fetus in 37 or 36 weeks or 30. So this time that USG is very, very important to see the weight of the baby and the amount of the liquor. Like in hypertensive disorders of pregnancy, in preeclampsia, all you have mentioned about the index and the important markers, like in PI, when we have to deliver the baby, or when we are going to induction of labor, or we have to continue up to the 38 weeks. So these are the things in a heart disease. You have that is some few medicines that you have said about this. These are the medicines that we don't know about, but it was also very informative. So one thing I will say to all the patients, the counseling is very, very important from the very beginning in the first trimester up to term or 37, 38 weeks of pregnancy. Because in the first trimester that you have said about the amount of the liquor and the CRL, two things are very important. Like in IUGR, the growth of the baby is important, the weight of the baby is important, everything. So thank you very much, Dr. Kuldeep. Your ultrasound, I know about your books. I'm having 2-3 books. Your is there. But
Thank you, ma'am.
before ending of this session, I want to thanks Archana for nicely she has explained my introduction. But two introductions she has left, that I was the past president, this ROCS from 2007 to 2009, and the peer reviewer of the Foxy Journal. And now I am the newly patron of this ROCS. And thank you, Sneha. And thanks to Jaideep, thanks Suman, everybody, and for this Medical Disorders of Pregnancy Committee. Thank you very much.
Thank you, ma'am. Thank you so much, ma'am.
Thank you, Kuldeep.
Thank you so
We'll
much,
call you in the
Deep
next.
sir, and thank you so much, madam. It was
Thank you. Thank you, Sneha. Thank you.
Thank you, Kuldeep sir, for your very elaborated and very meaningful talk. I think it has benefited our ROCS members. And now gradually we move on to the next session. And for this, I welcome our guest speaker, Dr. Girija Bagh, who is the Vice President-elect of Foxy. And she is going to talk to us on jaundice in pregnancy. But before that, I would like to welcome our chairpersons. We have Dr. Sasi as the first chairperson, and Dr. Archana Kumari, who is the current secretary of Ranchi OBGYN Society. So to begin with Dr. Sasi Bala Singh, can I have Dr. Sasi Bala Singh's CV? Sahiti? Yeah. So she has a very illustrative CV, and she is a very, very good friend of mine and very humble human being. As I have already said, she is also the president of ICR, vice president, numerous contributions to us, and has presented a paper in AOCOG at Hong Kong. I know she has also presented in Canada, and she's master trainer of skill worth attendant and nodal officer of Lakshya PPE.
Yeah, Suman, if you can please speak in front. Please speak in front. I think meanwhile we are not able to hear you.
Okay. So, and she has been awarded with MS Signature Award and Excellence in Teaching in January 22. So welcome Dr. Sasi Bala Singh. And now can I have the CV of Dr. Archana Kumari, a very dear friend of mine. As I've already said, she is the secretary of OBGYN Society of Ranchi, founder secretary of IFS Jharkhand.
So I think I have already been introduced. So
you have been introduced. So so I hand over the mic to you all, and Dr. Archana Kumari is going to introduce our guest speaker, Dr. Girija Bagh.
Yeah, it is indeed an honor to introduce formally Dr. Girija Bagh. Madam is the Foxy Vice President-elect of 2024. And we all know her, how revered teacher and excellent academician she is. She is the professor and head of Department of OBGYN, Bharati Vidyapeeth Medical College Hospital, Pune. And she's also the senior consultant attached to Cloud9 and Apollo Hospital of Pune. She has been the vice president of India chapter Gestosis, and she was also the chairperson of Medical Disorder Committee of Foxy in 2012 and 16. She was the member of Governing Council ICOG in 2011-2014, and she is the national mentor for Lakshya Ministry of Health and Family Welfare GOI, and I am fortunate that I am also associated with Lakshya, and she is a recipient of so many awards, including Anandbai Joshi Award for Excellence in Medical Services. And Madam, we are eager to hear from you about jaundice in pregnancy, such an important topic. And we all know how wonderful orator you are. I know all the Roxians are going to benefit from your talk. So over to you, ma'am. Madam, you have to unmute.
Please unmute, Dr. Girija.
Thank you so much for a very kind introduction. Just give me some time. Let me locate my presentation. 2 minutes, huh?
Yeah, by the time you locate your presentation, I just introduce you in a very special way. Dr. Girija Wagh is a revered teacher, very well said, Dr. Archana. She's a very close friend of mine, and we belong to the same institution and same class. Of course, the association has been so long, and I have been appreciating Dr. Girija Wagh for her academic contribution to various organizations. I'm sure the delegates will be benefited a lot from her talk. And over to you, Dr. Girija.
Thank you so much, Sneha, for that kind introduction, and also Madam Archana Kumari. I think, Sneha, I really would want to appreciate this particular opportunity, one, and secondly, I think it's a mutual admiration society. Being from the same batch, we really appreciate ourselves, and we are very proud to, we call our batch as 83, because we all took admission in MBBS that time. And I guess till now we have been able to do a lot of good to ourselves and the community around us. And I'm very proud of you for taking your knowledge and expertise to a very Mufasal place in the state of Maharashtra. And in our batch, nobody would have thought of going there and, changing your own routes and then going in a new place and entirely starting at a new hospital and making such a big name and serving the community. Really, really, I'm very proud of you. So coming to the crux of the matter, that is jaundice in pregnancy, we all know that whenever a woman comes with absolute yellow discoloration of the skin or the sclera, we are definitely concerned, because we know that there's something going wrong in her liver, and anything going wrong in the liver during pregnancy is innocuous, is quite dangerous, because we are always concerned about the safety of the mother, safety of the baby. At the same time, we are concerned about what's going to happen at the time of delivery, because if she's going to have liver damage, means failure of coagulation and all this. So it's always very important. We are not only obstetricians who are delivering babies, or gynecologists who are treating menstrual abnormalities and doing hysterectomies, but we are clinicians and physicians especially, and therefore we all have to be extremely well versed with the transport of bilirubin and what are the exact liver mechanisms that undergo during pregnancy and otherwise into creating jaundice. Now, whenever there is an increased production of bilirubin, there would be jaundice, reduction in the hepatocyte transport or conjugation, impaired excretion of bilirubin, impaired delivery of bilirubin into intestine, surgically relevant jaundice or obstetric jaundice as we call it, and usually cholestasis is something that we encounter quite commonly, which refers to the later two, where there is impaired excretion and obstructive jaundice. So these basic things we must be well versed with, so that we are able to approach our patients and identify and prognosticate them better. And as we can see, typically the causes of jaundice are arbitrarily divided into the prehepatic jaundice, which can be because of malaria, sickle cell anemia. There can be intrahepatic jaundice, such as viral infections, alcoholic liver, and then there can be liver cancers. And there can be post-hepatic jaundice because of obstruction, gallstones, or bile cancer. And this would all give rise to increase in the bilirubin level, giving rise to what we call as jaundice, giving rise to certain issues. And usually, if you look at abnormalities such as breakdown of RBCs, will give rise to release of heme, and then biliverdin converting to bilirubin. And whenever the bilirubin levels exceed 3 milligrams per deciliter, there'll be symptoms like yellow pigmentation of skins, mucous membrane, and sclera. So these definitely cause us to look into this matter a little more seriously. Now let's look at what happens during pregnancy. I'll ring the bell. Keep it here. Keep it here. So we all have to know that liver is not palpable during pregnancy. Serum protein decreases by 20% and bilirubin also decreases. In third trimester, alkaline phosphatase levels will increase up to 2 to 4 times the normal, because it is coming from the placenta. So alkaline phosphatase increasing in the third trimester should not cause a concern, but one has to keep a watch on the trend of what is happening. And it returns to normal in 2 to 3 months post-delivery. while ALT and AST that we typically call as SGLT and SGPT are normal, but they would increase during labor and normalize in 1 to 2 days postpartum. Now, we are all well versed with the other changes that occur during pregnancy, such as increased cardiac output and blood volume, increase in the circulating sex hormones, changes in the hepatic enzyme activity, especially the cytochrome P450, because estrogen is getting manufactured in large quantities, changes in the hepatic arterial and portal venous blood flow, changes in the production of clotting factors, which lead to hypercoagulable state, immunological changes such as shift in Th1 to Th2 cell response, increased cholesterol synthesis and excretion into bile and reduced gallbladder contractility, and pressure effects compress inferior vena cava and aorta, increasing during pregnancy. Now, so these are the various changes in the midst of which our liver metabolism would be situated. And that is what we have to be absolutely aware of. Now, the blood parameters change, which we should be able to interpret correctly, is there is reduction in the albumin, there will be no change in bilirubin, aspartate, transaminase, SGOT, SGPT as we showed, alkaline phosphatase in the third trimester, alpha fetoprotein would increase, international normalized ratios we have to see, INRs as we call it, prothrombin time would be normal, there will be reduction in the hemoglobin because of hemodilution, increase in the blood cell counts, platelet counts would be equivocal, cholesterol would increase, and uric acid would increase during pregnancy, and all these interpretations have to be in context. Now, typically diluted by 20 to 40% of albumin would be diluted because of the hemodilution. And there are certain 2 to 4-fold rise due to increased placental product. Plasma protein produced by embryonic yolk sac and fetal liver, diluted from second trimester due to increased blood volume. And if you look at the clotting factors, nearly all of them increase during pregnancy. Protein S and antithrombin 3 reduce with inhibition of fibrinolysis. And these physiological changes limit bleeding during delivery, but increase the risk of venous thromboembolism, which we have to be aware of. Now, jaundice is a yellowish discoloration of skin and mucous membranes we are aware of, and it will give rise to pruritus, pale feces, and dark urine, and is a sign of underlying disease involving abnormal heme metabolism, liver dysfunction, or biliary tract obstruction. And if you look at the normal bilirubin levels, they are always less than 1 milligram per deciliter. Levels over 2 to 3 milligrams per deciliter result in this presentation of jaundice. Now, bilirubin, if you look at, it's actually heme, which is metabolized by heme oxygenase to biliverdin, which is subsequently reduced to bilirubin. And unconjugated bilirubin is removed from blood by liver, conjugated with glucuronate and excreted in bile. While direct bilirubin is conjugated with glucuronic acid, water soluble, it dissolves in water, while indirect is insoluble and is also unconjugated. So these are the basic things that we all are well versed with. And if you look at the changes in liver function tests, we already discussed with them. But jaundice during pregnancy, unique to pregnancy, would be because of intrahepatic cholestasis, acute fatty liver of pregnancy, severe preeclampsia syndrome, HELLP, and severe hyperemesis gravidarum. We should always look for liver function test, and we should look for possibility of hepatitis as one of the differentials when women especially have excessive nausea, vomiting of pregnancy. Now, there are certain intercurrent illnesses such as acute viral hepatitis, drug-induced chronic hepatitis, which could be viral or autoimmune hepatitis, Wilson's disease, or the Budd-Chiari syndrome, which can be present. And they can be pre-hepatic causes such as hemolytic anemia, post-hepatic causes such as biliary obstruction, common bile duct stones, and common bile duct strictures. Now, if you look at the prevalence, IHCP, that is intrahepatic cholestasis of pregnancy, is found to be about 0.5 to 2%. Acute fatty liver is rare, but is the reality today and causes a lot of confusion when you're making our diagnosis, 0.01%. HELLP 4 to 12%, acute hepatitis 3 to 20%. Some parts of the country have very high occurrence of hepatitis. And cholelithiasis is also found, and nowadays with increasing obesity and lifestyle changes, cholelithiasis is found to be about 6 to 7% more, and sometimes they may entail necessitating. I have had experiences of doing a cholecystectomy during pregnancy in about 3 to 4 patients because of they go getting into cholecystitis, going into pancreatitis, and sometimes you may have to take this recourse. So when we look at intrahepatic cholestasis of pregnancy, there is obstetric hepatosis and icterus gravidarum. Typically, it is called as so. And it occurs in the 3rd trimester, but sometimes you may start having it in the late 2nd trimester as well. And you must be very, very sort of sensitive to women complaining about itching over the body, especially starting on the palms. It's reversible, resolves after delivery, and it is said to be because of circulating hormones of pregnancy. And sometimes I feel, especially in women who have take supplements during pregnancy, have a higher incidence of presenting. There can be also genetic reasons behind it. Now, the pathology behind this is impairment of the movement of ovuli, the biliary canal loculi, and that causes bile stasis. And that bile stasis gives rise to every issue that happens ends on. There is pre-existing covert defect in the bile transport, circulating hormones in the last trimester, over defect of the bile transport, and cholestasis is the result which happens. Typically, there will be 80% of the times they will present with pruritus. So whenever you have a woman coming to you with pruritus, it's always a good practice to do their liver enzymes, because you can have a start off. Maybe you may not immediately do the bile acids unless and until the enzymes come positive, because getting the bile acid reports takes a little while. Begins with the palms and soles typically, and then jaundice would occur in 20% of the times after 2 weeks of pruritus. So your pruritus is the first thing. Recently, we had a patient who presented with dengue and cholestasis. So dengue induced in the 3rd trimester. I don't know whether that was something to do as a response, adverse response to dengue viremia, but she did have, and then it was quite a challenge because she also developed post-dengue diabetes. And however, fortunately, she reached term and we could deliver her. Of course, the baby was a little large in size at the end of the entire stuff, and we required to deliver her by C-section. Now, bilirubin is elevated not more than 5 milligram per deciliter in IHCP. Transaminase is 2 to 10 folds, alkaline phosphatase 4 folds. However, serum bile acid is elevated. An elevation of serum bile acid more than 50 nanograms, and especially more than 100, is something which requires our attention, because that can cause fetal jeopardy. So once you know that there's ICP and the enzymes are increasing, it's a good practice to keep a watch on what is happening to the bile acids, and that can help you in trying to prevent any abnormal adverse effects on the baby. So the management of this condition is general care, where adequate rest, lot of hydration, low-fat diet, parenteral supplementation of vitamin K may be considered. Specific treatment, and I vouch by this, ursodeoxycholic acid, 300 milligram twice daily. Sometimes you may require to give a higher dose of 600 milligram twice daily if there is no symptom relief, or sometimes women are overweight. It's always better to give higher doses. They are completely safe, do not cause any problem or side effects. So in the past, they used to use cholestyramine, but it improves pruritus by binding to bile acids in intestine and increases excretion, while ursodeoxycholic acid modifies bile acid pool by displacing toxic concentrations of bile acids, improves pruritus and LFTs without maternal or fetal toxicity. And fetal care, as I mentioned, is essential. So do a close monitoring by sonography. If the baby is more than 32 weeks, you can consider doing NST. And it's always a good practice to electively deliver them by 37 to 38 weeks of gestation if they are not responding. But if they have stabilized, as I gave you an example of the patient, all her liver parameters and sugar parameters reverted to normal, and we could deliver her at 38 weeks. We were quite lucky, but then we have to keep a watch. And it's very, very difficult to keep on convincing patient and doing those repeated tests. Another very important disease, which is pregnancy specific, is acute fatty liver of pregnancy with an unknown etiology. It's believed to be due to mutation in the long chain 3 hydroxyacyl coenzyme A dehydrogenase, and it is a fatty acid beta oxidation enzyme no beta oxidation, accumulation of fat in the liver. Now, on histopathology, there is fatty infiltration of the hepatocytes, ballooning of hepatocytes, and microvascular steatosis with peripheral sparing has been found. And typically, it would occur in primiparas in the third trimester with the male baby, twin pregnancies associated with preeclampsia. Clinical features is vomiting, abdominal pain, jaundice, encephalopathy, pruritus, and ascites. Now, if you look at the lab findings, transaminase levels increase 1 to 5 folds, alkaline phosphatase 2 to 8 times, WBC more than 15,000, platelets less than a lakh, hypoglycemia, decreased clotting factors, and serum creatinine is raised. It is associated, what you want to say? It is associated with complications such as cerebral edema, renal failure, GI hemorrhage, hypoglycemia, septicemia, coagulopathy, fetal death, and severe postpartum hemorrhage. And that is something which is extremely daunting because they have a very, very severe coagulation failure. Now, delivering the patient and supportive care is the most important thing, and liver functions would return to normal soon after delivery. Usually does not recur in subsequent pregnancies, but we have to keep these patients under watch. So that is how we look at the acute fatty liver of pregnancy, HELLP. Hemolysis, elevated liver enzymes, low platelets is the HELLP syndrome. The etiopathogenesis, typically we know the same MAHA that happens in preeclampsia, where there is vascular endothelial disorder, platelet aggregation, consumption, fibrin activation, selective organic ischemia and insufficiency, microangiogenic hemolysis, and usually occurs in the second and the third trimester. Any woman presenting with not feeling well, right upper quadrant pain, epigastric pain, or vomiting and nausea or dyspepsia in the second part of pregnancy, one has to be looking at her as HELLP. Sometimes she may have help even with normal or just mildly increased blood pressure. And therefore, whenever these kind of symptoms are there, always rule out HELLP. Because it is associated with complications such as abruption, subcapsular hematoma of liver, hepatic rupture, DIC, and pulmonary edema. And HELLP is typically a laboratory diagnosis. So you look at hemolysis in the form of raised LDH or cystocytes on the peripheral smear, elevated bilirubin of more than 1.2 milligrams per deciliter, especially indirect, elevated liver enzymes, low platelets, and haptoglobin levels have been spoken about, but we don't do them in our country. We suffice by doing at the LDH and the schistocytes. It's classified by two typical classifications: Mississippi classification, which talks about platelet as a range, and then also speaks about elevated liver enzymes and hemolysis, while Tennessee classification says that it depends on the one or two characteristics which are available. Based on that, they will grade the HELLP syndrome. Now, what is more daunting is an expertise where we really require to look into is the differentiation between AFLP and HELLP. AFLP would be typically present in nulliparous twins, while HELLP would be seen in multiparous older, but we also see them in younger patients so often. Jaundice is common in AFLP and common in HELP. Ammonia would be high in AFLP, and encephalopathy is more likely in AFLP. Platelets are low or normal in AFLP, while they'll be definitely low in HELP. Prothrombin time is prolonged, which is normal in HELP. APTT is prolonged in AFLP, normal in HELP. Fibrinogen is low. Glucose is low, and that's the clinching diagnosis many times. Hypoglycemia, it's usually AFLP, and this would be normal or increased in fibrinogen, normal to increased, or glucose normal in HELP. The management is general IV access, assessment, seizure prophylaxis, antihypertensives, platelets, fresh frozen plasma, and of course dexamethasone for lung maturity. And some authors have also given dexamethasone for HELLP for stabilization, where especially the platelets are low. It's always better to deliver them after stabilizing them, and steroids would be definitely go, whatever time would be bought would be for stabilization of the mother's condition and for fetal lung maturity. And usually if they are going beyond at 34 weeks, we can consider delivering them. Now, the four types of hepatitis, the IHCP, acute hepatitis, HELLP, and AFLP. Typical clinical presentations, IHCP would be characterized by pruritus, while hepatitis would have jaundice, nausea, vomiting. HLLP, the hypertension, headache, gastric pain, and AFLP, there will be jaundice, nausea, vomiting. You can look at the liver enzymes, they'll be markedly elevated in acute hepatitis and AFLP. Serum bilirubin would be much more increased in acute hepatitis and AFLP following suit. Serum creatine will be normal in IHCP and acute hepatitis would be raised in HLLP and AFLP. Hemolysis is a characteristic of HELP and AFLP. Platelets would be usually normal in all the conditions, but would be abnormal in HLLP and AFLP. Coagulation profile would be deranged in all acute hepatitis, HLLP, AFLP, and therefore when it's happening close to the third trimester, close to a delivery, we definitely are going to be concerned. Now, acute viral hepatitis is a quite a commonality in much parts of our country and clinically would present with typical fever, anorexia, nausea, vomiting, yellow discoloration, and right upper quadrant tenderness. Diagnosis is based on elevated liver enzyme. We must consider doing specific viral markers, especially for better prognostication and treatment approaches. And especially hepatitis E is something which is causing a lot of concern nowadays. Management is symptomatic and supportive, adequate rest, nutrition, drugs such as neomycin, lactulose, prevention of complications, and avoiding sedatives and narcotics. HIV infection is fulminant in 1% in non-pregnant and 20% in pregnant women, and the fatality rate increases as pregnancy advances. Prevention is, of course, generalistic by improving sanitation. Pregnant women should not travel to endemic areas with known case of HIV. Hepatitis B is sexually transmitted. It can be vertically transmitted to the baby as it's a blood-borne infection. And many times we screen women for hepatitis, and we can sometimes find that there would be women who would be having chronic active or chronic persistent hepatitis B. They may be clinically presenting and biopsy may be recommended, but it's always better to recommend them to be seen to by a physician. Now, in the last few slides, it's very important that when you're delivering these patients, let's say hepatitis B especially, immunization of the newborn is mandatory stuff. Both active and passive immunization within 24 hours of delivery can be administered. And that is what would be the end of my talk. Thank you for giving me this time. And I hope I have been able to deliver what was expected, Sneha.
Dr. Sashibala, for your inputs.
1 minute. Good afternoon, everybody, and many congratulations to Dr. Girija for a very nice, informative, and excellent presentation of all the liver disorders in pregnancy. And you have very well explained about the physiology, pathology, and management of all the liver disorders which occurs in pregnancy. And you have explained it in this short time, in a very elaborate. And again, there is no time for us to read everything. But in your there was a very good revision of this talk. So we are very thankful, and this talk will be very beneficial for our day-to-day practice in the management of all liver disorders of pregnancy. So thank you, Dr. Girija, and thank you all who are listening to this. Thank you.
Yes, purposefully I have left this, I would say I have purposefully reserved this topic for the Professor Dr. Girija Wagh, because, everybody is scared of this least discussed topic, I would say. The one who has actually practically managed many cases should be able to speak on this subject, and that is what Dr. Girija has done. Evidence as well as experience. So we are very happy that you have done full justice to this topic, Dr. Girija. Thank you so much.
Yeah.
Thank you, and wish you all the best, Neha, for everything that you do.
Thank you so much, dear. Thank you.
Also, thanks to Dr. Sneha.
So, moving forward, can we go ahead with the panel discussion?
Yes, Dr. Archana, please introduce the panelists. I have been already introduced. So please
Yeah,
do not repeat. Yeah.
so it is time now for the much awaited, always pleasant to have discussion in the form of panel discussion, and that too on a very important topic of hyperglycemia and pregnancy. So I would invite and also introduce the esteemed panelist, Dr. Suman Sinha. We are proud to have her as chairperson-elect of Vijnana Surgery Committee of Foxy from Ranchi. We always adore her a lot, and she has so many other accolades. She has the experience of OBGYN for more than 30 years. She is currently the consultant in IVF Infertility Center, Ranchi. She has been the ex-CMS of and
One
also
line
the
only.
head of OBGYN.
One line only. It's okay.
Okay.
The next. So we can
CCL Hospital,
line.
Ranchi. So next we have Dr. Madhulika Horo. She is the Senior Medical Officer in the Department of Obs and Gynae REMS. And she was also the Vice President of ROGS, Vice President of ISOPAP currently. And she had been the past Secretary of ROGS. Welcome to you, Dr. Madhulika D. And now we have the young panelist, young lot, Dr. Samarina. She was also the past Joint Secretary of Ranchi OBGYN Society, and currently she is I think she is posted in Southern Hospital Ranchi, and she has been the faculty for DNB students over there. She has done tremendous work to get a DNB seat in Southern Hospital. Welcome, Dr. Samrina. Then we have a very young panelist, the vibrant one, Dr. Kadamini, and it's my privilege to introduce you. You have been my student, and it's wonderful to see you as a medical superintendent specialist in CCL Hospital, Gandhinagar. Our next panelist is Dr. Meenakshi. She is again the consultant gynecologist working in her own Khushi clinic in Ranchi. And she is also a very good academician. She is the member of MTP committee of Foxy. And she was the ex-senior resident and also assistant professor in MGM Medical College, Jamshedpur. Welcome, Dr. Meenakshi. And then we have Dr. Rupashri Purushottam. She is the fertility consultant in Evita IVF Center in Ranchi. And she is also the the secretary-elect of IFS Jharkhand chapter. So welcome, Dr. Rupashri, and over to you, Sneha, madam, for moderating the panel.
Thank you so much, Dr. Archana, for that introduction. It's a great help to me as well, knowing all the panelists here. And a very good evening to all of you. Indeed, it's a privilege for me to be associated with this, very friendly society. And I just go straightway to our panel discussion. I once again welcome all of you, Dr. Suman Sinha, Dr. Madhulika Horo, Dr. Samarina, Dr. Kadambini, Dr. Meenakshi, Dr. Rupashri. So I hope my screen is seen and it is full screen. Okay. So all of you know why are we worried so much about this diabetes, because it's the population of who is hyperglycemic or diabetes is growing. May it be type 1 or type 2 diabetes, may it be just a gestational diabetes, but almost 60 million women of reproductive age group worldwide, they have diabetes mellitus. And this is supposed to be doubled by 2030. So that huge is the problem. And at least 40% of these pregnancies, they are unplanned. So all of you know that this is a hyperglycemia, and it definitely affects the mother as well as fetus. Here you can see 2 out of every 5 women with diabetes, they are from reproductive age group. It accounts for almost 60 million women worldwide. And the prevalence of hyperglycemia in pregnancy increases rapidly with age and is highest in women over the age of 45. So looking about, just watching us, observing our demographic changes of our women who are, in this obstetric career, really we are facing the problems. And all of you know why this pregnancy is diabetogenic, because the placenta is.
Sorry to interrupt you, ma'am.
Uh-huh.
Are you able to see the screen, all the
Yeah,
panels?
madam.
Yes.
Okay.
We're not seeing it. Your screen is not visible to us.
Madam, your slides are not visible. That's what I wanted to tell.
Yes, yes. Let me see. Actually, I have shared it. Let me.
No, but your screen, you are visible on the screen, not your
Let
slides.
me. Is it?
Now it's
Next,
starting.
yes.
Yes.
Yeah, now it was visible.
Okay.
Make it
So,
full screen. Yeah.
so yeah.
Now it's okay.
I hope that's the reason I asked you whether the screen is visible. So now is it okay?
Yes, ma'am.
Yeah. Okay. So because of the placental hormones, estrogen, the cortisol, and the human placental lactogen, these hormones, they antagonize the action of insulin, thereby peripheral utilization of glucose, and thereby leading to hypoglycemia. And this blood with high blood sugar level, when it enters the fetal circulation, it stimulates the fetal pancreas and leading to excessive insulin utilization of the sugar and a fat baby, that is macrosomia. So, Suman, why are we worried so much about this hyperglycemia in pregnancy?
Thank you, madam, for the question. As we all know, gestational diabetes mellitus is associated with adverse maternal and fetal outcome. Among the maternal outcome, it is the risk of preeclampsia, hydramnios, then hydramnios, preeclampsia, prolonged labor, then there is risk of PPH, then obstructed labor as well, because the fetus is macrosomic. And there is also risk of later on she can become she may suffer from vasculopathy, as well as she may become a full-blown case of diabetes mellitus.
Yes.
And among the fetus abnormal outcome is that fetal is already a macrosomic fetus. There is threat of macrosomia because the fetus is maybe large for date. Then there is risk of shoulder dystocia in the fetus. Fetus may suffer from respiratory distress syndrome.
Right.
And fetus later on, fetus may become diabetic or obese.
Yes, you're right. So very well covered, Dr. Suman. Right from the early pregnancy, you may have even the spontaneous abortion, preterm labor, though in some cases you have postnatal and large-sized baby with the associated complications. Definitely when you have the neonate, also the neonatal hypoglycemia, the very well-known hyaline membrane disease, what we used to call it as respiratory distress syndrome, and of course the hypocalcemia, hypothermia, prolonged jaundice, all these complications, they are also associated with this hyperglycemia. And as you rightly said, that long-term complication is obesity, and the metabolic syndrome also can be there. And that's the reason we are very much worried about this. So how blood sugar levels, I mean, we always say that if at all she has diabetes before pregnancy, we should optimize these blood sugar levels. Are these blood sugars directly related to perinatal mortality? Yes, Dr. Suman.
How blood sugar levels are related to perinatal? Yes, madam, because perinatal mortality has been seen that when the blood sugar level is more than 200, then there is risk of 35% of death of the fetus. If it is around 100, then you see the rate of perinatal mortality is decreasing. It is around 4%. So it is very pertinent to keep the mother should be
Right.
her blood sugar must be under control.
So the blood sugar levels are directly related with the perinatal mortality, as you can see here in this table, and that is why there is a stark necessity for the blood sugar levels to be under control. And of course, the nutritional counseling and guidance along with the medication. So whether she's taking the medication as oral medication or insulin, nutritional counseling has got a very, very vital role here in the man. And the lady has to be informed that, if she wants to plan her pregnancy, the target blood sugar level should be such that before breakfast, it should be between 69 to 90, and pre-lunch and pre-dinner, that is before meal, it should be between 60 and 105. and post meal it should not exceed 120 mg/%. Okay, so very well discussed, Dr. Suman. We go now with this first case. We have very interesting cases, almost 6, 7, whatever we can cover. I'm trying to cover. So, Dr. Madhulika, we have this patient for you. A young primary gravida, she's coming to you for the first antenatal checkup at 10 weeks of gestation. When you examine her, you find her height is 152, weight is 69 kg, her BMI is 30, and she does not have any family history of diabetes. Tell me whether you would like to screen this patient for GDM and how. Whether you would like.
Yes, ma'am. Because GDM is very high in patients with PCO obesity, and our patient is obese. She comes in obesity, in a group of obesity, although her age is quite, she's quite young, but she's obese.
Okay.
And so we have to screen the patient, and according to national guideline, irrespective of the first, irrespective of her fasting status or the timing of last meal.
Yeah, I would like to interrupt you here. Just because she's obese and with advanced age, I mean, not advanced age, just because she's obese, you want to screen her, or you want to?
Every patient should be screened. Every patient should be screened.
So that is what the message we want to give. If you remember, 3 decades back, we had this concept that obese patient, age about 35, the one with family history of diabetes and one who is PCO, we should screen.
They carry more high risk. That I wanted to say. And in a first visit, she should be screened, and after between 24 to 28 weeks, and again at around 32 to 36 weeks. But if patient comes late in pregnancy, only one test is sufficient to.
Okay. So how? I mean, which set? Whether you want to do random blood sugar, fasting, or 50 grams, 75, 100 gram, 100 milligram. You tell me which.
75 gram glucose dipstick test.
Okay. So tell me, when do you want to screen this? You have already answered this question, that irrespective of her fasting status and the timing of the last meal, you would like to screen her in this sequence. And if she comes late in pregnancy, only one testing should be sufficient. So very well discussed, Madhulika. The message goes very loud and clear that every woman during every pregnancy, not that she is second gravida, first time she was screened, so no need. So it is not that. Every woman during every pregnancy. So thank you so much. And now we come to Dr. Sabrina. How do you do this test? And can you just tell us in details?
Yes, madam. The GCT or the O'Sullivan's test, that as Madhulika ma'am has told, that it is done irrespective of the last meal and irrespective of the timing of the day. It is done like with 50 gram of oral glucose, and the venous
I would
blood
like
is
to
measured.
interrupt you here. We have had a consensus that only 75 grams of single state oral glucose tolerance test should be done. So we have a consensus here that only 75 grams single state test should be done. Okay. Do you all agree to this?
Yes.
Does the panel agree to this? I have just shown you this figure that DIPSI, the Diabetes in Pregnancy Society of India, NHM, the National Health Mission, Ministry of Health and Family Welfare, Government of India, FOXI, and ICOG, all of them recommended 75 grams single step OGTT. Okay. So we have a consensus here because our parent organization who will protect us if anything goes wrong, they are recommending this test. So we should follow only this test. Okay. Do you agree, Dr. Samarina?
Okay, ma'am. Yes, madam.
Okay. Yes. So we go ahead with the testing. Details of the testing. Yes. 75 grams instead of 50, 75 grams. Okay.
Yes, ma'am. 75 gram, and here.
Okay. Anybody else want to take this?
Yes, ma'am.
See here, I have also projected for you. Does anybody want to discuss this test? What you have been doing? Yes,
Sabrina,
Dr.
you can take now. It's written over here. Just read it, Sabrina.
Dr. Rupashri?
Yes, ma'am. Yes, it's a very patient friendly. Whenever the patient enter into the hospital, irrespective of the time, anytime we can go for the steps. Here we provide the patient 75 gram of glucose, and 2 hours after that, we take venous sample, and that is sufficient. If the range comes in more than 140, it comes under the GDM group, more than 200 diabetes. And if it is 120 to 140, it is glucose intolerance, or we can say the borderline
glucose intolerance.
Glucose intolerance. And less than and if it is less than 90, it's non-diabetes.
So Dr. Samriana, once again I come to you. Suppose when you are giving this, glucose to drink for this lady, and she vomits out maybe 10-15 minutes after that, should we continue this test or should we abandon the test? Do we have Dr. Samriana here? Okay, so I will just say it out that, what you have to do is you give 75 gram of glucose dissolved in 200 to 300 ml of water. Ask the woman to consume it over 5 minutes, slowly, of course. Then if at all, that time you have to note the timing, and after 2 hours, you have to go for the glucose testing, plasma glucose levels. Now, if this lady vomits out within first half an hour, then you have to discontinue the test. But if she vomits out after half an hour, you can go ahead with the completion of the test. You have already said about the interpretation of the test. So we have to do testing universally for every woman during every pregnancy with 75 gram of single step OGTT. Okay. So now we come to the second case. Purposefully, I have taken very, very short case discussions so that the message goes very clear. Okay. So Dr. Meenakshi, we have this patient whose fasting blood glucose levels have been done prior, and she comes to you with a report of fasting blood sugar level as 86 milligram percent, HbA1c 5.6%. Okay, Dr. Meenakshi.
Hi.
Yeah.
Good evening, ma'am.
Good evening. So we have fasting blood sugar 86 milligram percent, HbA1c 5.6%. We have just discussed how to diagnose GDM, right? How to screen for GDM. So does she have diabetes?
No, ma'am. She is currently not having diabetes because her because fasting blood sugar is normal. And
does she have GDM?
It cannot be said based on just a fasting blood sugar and HbA1c. We have
that
to
is
do
what the answer is
test.
expected. So, does she have GDM? You will not say no, because this is not a screening test for GDM. Okay, we have discussed what is the screening test for GDM. Does she need to be tested again, and which test?
She need to be tested by DIPSI method, by giving the 75 gram of glucose and taking the sample after 2 hours. And this, if she is her DIPSI test after 75 gram of glucose, her blood sugar level is already 168 milligram per
This we will talk
deciliter.
later. So if that we have to measure by DIPSI test. So Dr. Rupashri, when we did her DIPSI test, her blood sugar level was 168. Now, is she a case of GDM?
Yes, we can assign such patient as GDM patient.
Yeah. And in what treatment should we put her under treatment immediately? If yes, what? If no, what?
Yes, it's very important because as this patient are and we all are well aware of this fact that 75 to 85% of patients respond well with the dietary counseling, exercise, and lifestyle modification. So here, the main is the medical nutrition therapy is the cornerstone of the treatment.
Yes.
And possible, we can seek help of a dietitian. If not available, we can also give a diet chart according to the BMI of the patient.
So what my question second is, does she need treatment or is treatment indicated? No medication as such. It's only the dietary counseling and advice. Okay. So just to summarize, you have a pregnant lady who comes to you for the first time. you advise immediately the moment she comes to your clinic, you see that the UPT is positive, you give her 75 grams of glucose to, dissolved in 200 ml of water, and you ask her to drink. Note down the timing. You withdraw her blood sample at 2 hours, see whether the blood sugar levels are more than 140 or less. If it is less, well and good. She is non-diabetic, she doesn't have GDM. You repeat her testing after 24 to 28 weeks. And then if that time she is again negative, you manage her as normal pregnancy. But any time during this course of testing, if her blood sugar level crosses 140 mg%, then you have to label her as GDM. And then you have to give her 2 weeks time. Okay. Okay,
Yes,
now somebody to speak on this 2 weeks time. Yes.
Yes, ma'am. Yes, with the dietary advice, we can follow the patient after 2 weeks. And again, we have to go for the PP level, blood sugar PP level. If it comes under 120, we can
PP
continue.
is how many hours? 2 hours.
2 hours postprandial.
Very specific, yes.
2 hours postprandial, and if it comes below 120, we can treat a patient with the medical nutrition therapy only.
Yes.
And if it is more than 120, either we have to switch over to the medical management like metformin or insulin.
Yes. So the pharmacological agents we will decide, but she needs medication if the 2 hours postprandial glucose levels are more than 120 mg%. So naturally, diet, exercise, if it is not controlled with this, after 2 weeks, then definitely you have to start on some medication, metformin or insulin. We still are having some debate. We will come to it later on. Now, why diet is so important in the management of GDM? Dr. Suman, this is a question for you.
Yeah, yes, madam. Diet is very important because it will give sufficient nutrition to the mother, as well as it will help in the fetal growth. And if we control if diet is controlled properly, then her blood sugar level will be also under control.
Yeah. So first and foremost, it will give adequate calories to the mother, to the fetus. It will provide adequate nutrition, and it will also help in controlling the blood sugar. It will also help in managing the appropriate weight gain. Okay. So all in one, even when you are restricting the diet, it will help to provide or take care of all these aspects. So food plan, it is very, very important that, nutrition intervention is recognized as the cornerstone of the therapy, and almost 90% of these women, they respond to this medical nutrition therapy. Only 10% women, they require some pharmacological agent. That is also our experience. I have been practicing high-risk obstetrics now since 31 years. But medical nutrition therapy is very, very effective as far as the control of GDM is concerned. Okay. And of course, your role is very, very vital, because if you are settled at a, metropolitan cities, you will have dietitians separately. But it is not very difficult also for us to plan the diet of such women. You have to only discuss and individualize. We are coming to it, how we should individualize. Now, I would ask Dr. Madhulika to take up this question. For a normal average pregnancy, what should be the average weight gain? And for that, what should be the caloric requirement? Normal.
Actually, madam, it should be 11 to 10 to 12 kg. Total weight gain should be there.
Yeah.
And it depends upon the level of activity of the patient and the weight of the patient. It depends upon that.
Yes.
If she's a normal weight, we can allow her to gain up to 11.5 to 16 kg. But if the patient is underweight, we can extend up to 18 kg. But if the patient is overweight, it should come down to 7 to 11.5 kg.
Okay. What about the calories?
Calories, it should not exceed more than 1600 calories. And total should be, for a normal sedentary worker, should be 1900.
We are coming to it. But then on an average, when we talk about a pregnancy, for her particular weight, 350 calories extra for what she was
350
before
calories
pregnancy.
added
Okay,
extra. Yeah,
but
yeah.
if she's underweight, 500 calories extra.
We can have, we
She's
have to add
overweight,
500. If it is obese, we have to minus 500. Yeah.
yes, perfect. Okay, so Dr. Madhulika, what are the
Yes.
factors to be considered in the caloric requirement? Now we come to the proper.
Her level of activity, ma'am. First, if she's a sedentary worker,
Mhm.
it should be between 1900 plus 350. If it's a moderate worker, it should be 22 to 300 plus 350. And if she's a heavy worker, it can be, it should be about 2850 plus 350. That is around 3200 calories should be
Perfect. Perfect.
given.
So your pre-pregnancy weight and BMI, along with your level of activity, will decide actually how much is your caloric requirement. Okay, that will differ. Yes.
Yes.
So FIGO also says that, you know, nutrition counseling and physical activity, these are the primary tools in the management of GDM. And FIGO recommends that women with GDM should receive practical nutrition education and counseling that, you know, empowers them to choose the right quantity and quality of food.
Yeah.
Women with GDM must be repeatedly advised to continue the same healthy eating habits after delivery to reduce the risk of future type 2 diabetes. It's not
Yes,
that
ma'am.
pregnancy, delivery and all that is over. In fact, they have to maintain this active physical lifestyle even after the delivery. Okay, so what all things, we have talked about the caloric requirement. Now, how do you screen this patient? Okay, during first trimester, what all things need to be done?
We'll measure her blood sugar, HbA1c, and we'll examine the fundus examination for evaluation of retinopathy and evaluate for nephropathy by serum creatinine. And for fetal, we'll go for dating scan and scan between 11 to 13 weeks of gestation for CRL and knuckle translucency. And biochemical screening will go for beta HCG and PAP-A.
Okay. All of you know what is the fallacy of NT scan, because in this diabetic women especially, the screening test for aneuploidy when you are doing in poorly controlled diabetes, the NT may be raised, you know, and of course there can be a risk of congenital heart disease rather than aneuploidy. See, when you have the elevated level NT knuckle thickness, we think of aneuploidy. But here it is mainly the congenital heart disease. Okay. So that is all about the medical nutrition therapy, how you can control your patient only on diet. So now we come to the next case. And Dr. Suman, once again, I think we are directing these questions towards you. You have this primary, 16 weeks. Parents are diabetic, and she comes to you with the following report. Her GCT is 179 milligram%. What will you do, Suman, with this report?
Madam, she seems to be a case of GDM with the history also. Her parents are diabetic. So for 2 weeks, we can give her medical nutrition therapy as well as a little bit of exercise. And after 2 weeks,
what do you mean by little bit of? In fact, we are going to discuss how much.
Yeah, I will do that. Yeah, and so we will also tell her to regular exercise for 30 minutes per day, and better if she takes the exercise after each meal. So that will be much better.
Yes.
And after 2 weeks, we do the postprandial blood sugar. Yeah. And if it is more than 120, then we are going to put her on medical treatment that will be either with metformin or glyburide or with insulin.
Okay. So, Dr. Madhulika, what diet modification would you like to do for her and how?
Our principle is about her weight gain. It should be between 10 to 12 kg. And if the patient is obese, it can be, the calorie should be between 25 to 30 calorie per kg. And for non-obese, it is 35 to 40 kilocalories per kg. But dietary compliance should be evaluated and reinforced. And previously we discussed about her the level of activity and BMI.
Yes. So we skip that. But suppose, you know, your patient is having, how do you help her for her diet modification? You know, she's saying, I'm having
diet should be More of carbohydrate should be about 45%, protein should be 35%, and
how much
fat
should be the
25%.
carbohydrates? How much should
If you
be
see
the
the
carbohydrates?
chart, yeah. If you see the chart, the plate should be half filled with non-starchy vegetables, and one half should serve the, or palm side should serve the protein, and the rest is starchy food.
Yes. So instead of having lots of carbohydrates at a time, maybe you can advise her to divide these meals into small meals. Yes, that is what the most important. Yeah. Now, when we are talking about medication, I think somebody else, Dr. Rupashri, Dr. Samrina. Do we have Dr. Samrina?
Ma'am.
Dr. Samrina?
Yes, madam. Yes, madam.
Yeah. So this is a question for you. Suppose our patient, she stays, everybody's talking about insulin being the first drug of choice. And definitely one should prefer for insulin because of the various advantages which we will be discussing also later. But you have this patient who definitely has GDM, and her sugar levels are not controlled even after 2 weeks of diet and exercise, and she needs medication. But she stays at such a village that she's from a low socioeconomic strata, and she's not educated, she's not able to monitor her blood sugar levels. What is your drug of choice, whether metformin or insulin?
Metformin.
Yes.
Metformin, and if it is not controlled on metformin, then we start insulin by educating
No,
her.
I'm asking you, if she is not controlled on diet, MNT, then what medication you want to start?
Metformin, madam.
Yes. The reason being? What is the reason? Why do you want to start metformin? Why not insulin?
Ma'am, because she's in a remote village, there will be episodes of hypoglycemia. It will be difficult for her to control.
Perfect. Because, for insulin, whenever you want to start insulin, you initially, at least when you have, started the insulin, some people recommend at least 7 point of testing. Some people recommend at least 5 point of testing. But for all practical purposes, at least 1 fasting, that is before breakfast, and 3 post meal, that is 4 times sugar levels. Initially for first 3 days, then once she is stabilized, then you can, go for every 3rd day blood sugar levels. But such patients who is not educated, not able to monitor herself, and there are no healthcare workers who to guide her also. So for her, giving insulin, it will be more risky, and that's a very reason she should be put on metformin. Now, any specific advice for exercise you want to give, Dr. Samrina? What kind of exercise?
Mild to moderate exercise should be advocated. ACOG also recommends aerobic and strength building exercise. There should be some walking after meal so that the postprandial value is controlled. And exercise goes a long way in reducing the insulin resistance. It keeps the patient euglycemic, and the insulin requirement is also reduced. And the pregnancy weight gain is also under control, so the level of macrosomia, the complication of macrosomia is also reduced. So these are the advantages of exercise.
So at least 30 to 45 minutes of moderate exercise has been taken, unless there is some obstetric contraindication or medical contraindication. So the exercise will be like brisk walk and some household work, arm stretching exercises. Because our pregnant lady, you have to, also see that she doesn't lose her balance and she doesn't fall off. So you don't have to tell her something very difficult exercises. Even the brisk walk should be okay for her. Okay. And even the household work. That is how you need to at least 30 minutes a day, 5 days a week. So 150 minutes of exercise, moderate exercise should suffice for her. Okay, so we have come to the conclusion of this case saying that MNT for 2 weeks, then you repeat blood sugar levels 2 hours postprandial. If normal, you continue with medical nutrition therapy. If it is not controlled, you started on medication. Depending upon her socioeconomic status, level of education, and her ability to monitor herself. Self-monitoring is very, very important. And that is how you have to decide which medication. About safety and efficacy, we will come to it a little later. So, Dr. Kadambini, do we have Dr. Kadambini here?
Yeah. Yes, ma'am. Good evening, ma'am.
Good evening, Dr. Kadamini. So we have this young, the primigravida with 20 weeks, not young exactly, but we have this primigravida 20 weeks. The parents are diabetic and she comes to you with the following reports. Again, the parents are diabetic. Blood sugar fasting is 95, postprandial is 175 mg/cent. What is your reaction? Is she having diabetes? Is she having GDM? What is your opinion?
She looks to be having GDM, ma'am. We can go for a DIPSI test to confirm it with 75 gram of glucose orally over 5 minutes. And
with this high blood sugar level, should we subject her to obesity? Are we not adding her to the risk?
We can directly go for the treatment part either, or we want to confirm it with DIPSI, we can go for that.
Okay. What about HbA1c? Do you want to see whether he really, I mean, is it a single reading or is it, over last 3 months, what is her blood status like? So HbA1c has a role here to play.
Right, ma'am.
Yes.
Right, ma'am.
So,
HbA1c should be evaluated, and its value, if it is less than 7.9, then there is high chance of congenital malformation, like 6.9%, and she should be told about it.
Once again, I would ask you to repeat what you are saying.
Ma'am, if HbA1c level, that tells about the mean blood sugar level over 4 to 8 weeks prior. If she has value of HbA1c more than less than 7.9%, then she has 6.9% chance of congenital malformations. And if HbA1c level is like 8 to 10%, then she has 19% chances of malformation.
Okay. So the maximum chance is when the HbA1c is more than 10. Okay.
Right. If it is more than 10, then she shouldn't have planned for the pregnancy. But here it is the case that she has come with pregnancy 20 week already. So she must be told about the chances of malformations.
Okay.
And now, first thing, MNT, of course, should be given to all the patients. Then exercise, as Madhulika ma'am and other panelists also discussed, should be she should be subjected to exercise also.
Okay.
And besides that, she should be started with the medications. Insulin would be the preferred
medication. Whether you want to see
medication.
the levels after 2 weeks of MNT, the postprandial? Yes.
Yeah, of course, ma'am. 2 weeks, we will check
you will
the
offer
levels.
her guidance regarding diet modification and the exercise. Then you will repeat her sugar level.
Right. Right. After 2 weeks, I will repeat the plasma blood sugar level. And if that comes less than 90, then she is normal. If it is more than 120, then she should be.
We're talking about the 2 hours postprandial levels. That should be less than 120. If it is less than 120, then there is no need for medication. She can continue with the, Okay. If her blood sugar levels are more than 120,
then we can start medications.
Yeah, okay.
Yeah.
So, what are the pre-pregnancy therapeutic goals? Just to have, so because you're getting these patients who are already diabetic. So the moment they come to you, you want to confirm and you want to do her evaluation whether she's already suffering from this. Otherwise, tomorrow, when you are managing, all of a sudden she lands up with the retinopathy or so, the patient will blame you. So at the very first point of diagnosis, you will evaluate her for various complications. So what will you all do?
I will suggest the patient to go for tests regarding retinopathy, nephropathy, neuropathy. And AAC recommends that value of HbA1c should be less than equal to 6.5% to have less of chances of these complications as well as congenital malformations.
Okay, perfect.
And if pre-pregnancy level is already more than 10%, then patient should be discouraged to have pregnancy. She should be put on diet, MNT, and exercise, and if needed, then drug therapy.
Should we advise her MTP?
Pardon, ma'am?
Should we advise her for medical termination of pregnancy?
we can go for other tests like screening
just
for
asking you,
congenital
yes or no
abnormalities.
first.
No, ma'am. I will not go directly for
Yes,
termination.
that is what it should be. You have to
Yes.
just get the patient evaluated.
Yes.
You have to just help her taking the decision. You will not enforce any decision on her.
Right.
And whatever you are talking to her, you have to write it down in her own handwriting, saying that the informed written consent has been taken. May it be for termination, may it be for continuation of pregnancy. Okay.
Yes, ma'am.
Okay.
Yes.
So you have done all this, and if there is no control, then you can start insulin or metformin. We have discussed about this, that lifestyle modification, if alone it fails, MNT and lifestyle modification, you have to start with medications, and metformin being one of the metformin and insulin. As far as the safety and efficacy is concerned, they are similar. Okay, this is what you can see. This is the Maternal Health Division, Ministry of Health and Family Welfare, Government of India, and NHM. Okay, so this is a proof. This is a support of your, whatever you are practicing. If your patient is a case of PCOS, if she is already on metformin, no need to stop it, continue. Okay, but if you have to start a new medication during first trimester, try to avoid metformin. Okay. That is what recommended. Try to avoid during first trimester. Maybe if at all she needs, you can go for insulin for first few days, and then after 20 weeks, again you can continue her on metformin. So that is how it is. So this is just to summarize. These are various organizations unanimously saying that insulin and metformin, they are equally cost efficacious. Okay, so you need not worry. Even people have been coming up with studies that even during first trimester, metformin is safe. So maybe a time will come that you may go for metformin as a priority drug. Okay. So this is I will just ask you, when did you start insulin directly? Anybody can take up this now. Now you pass on the question to someone.
Insulin may be started if she is in hospital setting, or even in OPD basis she can be given, but she should be told about self glucose monitoring as well.
Yes.
Ideally, it can be done for 7 times a day, but if not possible that much, then she can go for 4 tests a day at least, in which one should be fasting blood sugar level, and
that
other
is what we have discussed already. One fasting and 3 post-meal.
3 postprandial.
Yeah. So what Dr. Meenakshi, I'm trying to ask Meenakshi, which are the patients for whom you have to directly start insulin?
If the patient's fasting blood sugar level is more than 120, and after 2 hours it is more than about 199, etc. So we can directly go for insulin therapy along with the diet and exercise also.
Yes. So in spite of all this, if at all you have, even at diagnosis, if you have 200, that is more than 199, the sugar levels, then also you have to go for the insulin directly. And as we have discussed till now, the 2 hours postprandial blood sugar levels after 2 weeks of MNT, if it is not controlled, then you have to go for insulin, because that is a first drug of choice. Okay. Now, these are the lab tests for plasma glucose levels. This is how the self-monitoring of blood sugar levels. Dr. Rupashri, I would just ask you, how will you do the surveillance of this? For first trimester, we have already done. For the second and third trimester, can you just throw some light on this?
Yes, ma'am. In 2 ways, we have to go for the surveillance, like maternal surveillance. Here we will keep track on the blood sugar monitoring, and patient are counseled for, because we require, if the patient is on insulin, we require frequent monitoring. So we should counsel the patient for self glucose monitoring by the glucometer. And initially after 1 week, it should be calibrated with the lab report also, so that whether the reading is right or not, we must have to check that. And if then fortnightly, we can go for the PP level up to 28 weeks if everything is normal. And after 28 weeks, we should go for weekly test of the sugar with PP level. If the patient is on MNT therapy. If patient is on insulin, then till the time the patient get used glycemic, either we can go for the 7-point test or 5-point test, and once the sugar level is established, we can go for the staggered approach also, where one day we go for the like fasting, another day for pre-lunch or post-lunch, and another day for, in this way we can keep a track on the sugar monitoring. And as part of the fetal surveillance, in the second trimester, as in normal pregnancy, we go for the anomaly scan, that should be done. Fetal echo must be suggested, as such patients have higher chance of congenital heart disease.
Yes.
And no other vasculopathy or something is associated with the with the patient.
Mainly what we are suspecting here?
Ma'am, yeah, preeclampsia. If vasculopathy is not associated with, we would go for the growth scan like 28 weeks, 32 weeks, 36 weeks. But after that NST as required. But if the patient is having vasculopathy or IUG or a preeclampsia, then we have to go for the color Doppler test also, like urinary artery, MCA, and umbilical artery.
Yes,
So in this
very
way,
good.
we have to monitor the patient.
So we come to the fourth case now. You will inform me whenever you get tired or bored. Should we go ahead with this case, Dr. Suman?
Yes, madam.
Yeah,
Yes,
we
ma'am.
have this primary gravida, 33 years old, 7 years infertility, obese PCOS. She conceived on treatment. So all high risk factors. So she continued her metformin, and she is still, in spite of on metformin, she's diagnosed as GDM at her first visit. Controlled on MNT. Her sugar levels are controlled on MNT. Though HbA1c is 6.9 at 33 weeks. Okay.
Here we see, yeah, madam. Here we see that HbA1c is under limit only. No? It is 6.9, not very high. It is under control.
Yeah.
But one thing is very important, that the baby is macrosomic.
Yeah, but then what should be the ideal HbA1c?
It should be less than 6.5. Better. Yeah.
6.2 ideally. Less than 6.2. So here definitely the HbA1c levels are
so somehow patient needs a good control of her blood sugar.
Yeah.
And for that, I think here I will add insulin.
Yes.
Apart from checking her diet, what she is taking, is she going for regular exercise or not? And if not, we will advise that you just keep check of on your diet. You take proper meal, which is advised for diabetic patient.
We have said, Suman, that she's controlled on MNT, but her
then also, madam,
is not.
But she is not controlled because baby is going macrosomic. So we have
to. And the HbA1c is high. Okay.
Yeah. So we have to
have gone wrong. What should have been added since when? Because in spite of being on metformin right from before pregnancy,
he's taking, but we can add insulin in this case.
Yes. So this is a case where right from the beginning, you should add insulin, because she's already on metformin, because she's obese, she's already having whatever diet modification and exercise. In spite of that, if she develops GDM, that is an indication to start insulin here straight away. Okay, so GDM is diagnosed before 20 weeks, and obese PCOS, where she's already on metformin, she's following the diet modification, and she's doing the active physical exercise. In spite of that, if she's having the poor control and the baby is macrosomic, this is a patient who needs insulin on priority. Okay, and such woman is very, very at risk of having a stillbirth, unexplained stillbirths. We are so happy the baby is healthy and all these things, and all of a sudden we lose the baby. So for her, monitoring of blood sugar levels, insulin, you take her to 37 weeks and you go for cesarean section, elective cesarean section. Okay. So Dr. Madhulika, we have this, one of the major concerns in women with diabetes in pregnancy is macrosomia. So can you diagnose this at the earliest, on ultrasonography? Do we have early indicators?
Weight estimation can be done only in third trimester, and only 51% of sensitivity. Abdominal circumference gives a good idea about the weight of the baby.
Yeah.
So it is more 4,000 gram to 4,500 gram of macrosomia, and it can be associated with polyhydramnios.
Yes. So
Five
that
more
gives
than
you an
20.
indication only during third trimester. So we cannot have an early indication for
Yeah, we can have an
microsomia.
early
That is the
indication,
worst part of it. Dr. Kuldeep
yes.
has very nicely talked about the abdominal circumference and all those things. But definitely your clinical judgment of, control of blood sugar, HbA1c levels, and the serial scans, that you have to, you have to keep a very high index of suspicion. Even 1 point goes this side, you have to keep it, higher on your list, that yes, she may go for macrosomia. So Dopplers, we have talked about the uterine arteries, umbilical arteries, and for the detection of, IUGR also. So right from early pregnancy, even if everything is fine, if she has uterine artery pulsatility index higher, there is a chance for hypertension and of course the MCA. So for redistribution, this is for the other end of the spectrum, the fetal growth restriction we are talking about. So we have this case, and I think we have this last case, and then we will wind up. So second gravida, para 1, 36 years, with previous one cesarean section. Now she's 26 weeks, diagnosed as diabetic during third month only, over diabetes, and she's on insulin now. HbA1c is 6.5, her blood pressure is 159. 90, and clinically there is a small for gestation age baby. How do we manage this patient, Dr. Kadambini?
Yes, ma'am. There are so many risk factors here. She is diagnosed diabetic during third month. HbA1c level is just borderline 6.5. Her BP is 150/90. That means she is going towards preeclampsia. And the baby is having SGA. That is, she is elderly, more than 35
and
years.
she's got one previous seizure. So,
right. Yes, ma'am. So many things are there. And now we'll go for investigations like biochemical markers, dual marker, that is papain beta HCG is done at 9 to 10 weeks. Then we can go for biophysical anti-scan at 11 to 13 weeks, that we normally also go for. Cervical length is tested to look for the cervix. And quadruple test should also be suggested at about 14 weeks of pregnancy. We can go for uterine artery Doppler because preeclampsia chances are there. So PI index will tell us about that. And these are the tests like PAPE, PIGF, SFLT, MAP, and uterine artery PI. If these all are done, then 91.4% chances of detection of anomalies are there. Target scan can be done for the ultrasound to rule out other congenital anomalies in the baby. And besides, since she is having previous cesarean sections, so we can go for test USG
I'm
to
sorry,
see
not
morbid
we can.
adherent placenta.
We must go for.
Yeah, we must go for.
Look for. Yes.
We will go for. Yeah, ma'am.
Okay.
Now,
this all we
since,
have discussed how to monitor. Only important
yes,
points: maternal and fetal monitoring. After this, how you would go for?
Fetal monitoring will be done for growth and well-being of the fetus, and maternal monitoring, self-blood glucose checkup should be told to the mother 7 times a day or 4 times a day, as we already have discussed. And besides, she can go for other tests like platelet count, liver function tests on the line of preeclampsia.
Yeah.
And in this case, we can start with the labetalol also because she is having blood pressure 150/90. I think if it and other consensus are there in that if blood pressure is 140/90 or above, we can go for drugs to control blood pressure like labetalol.
I think sometime we will have a discussion on hypertensive disorders of pregnancy as well.
Yes.
We have the panel discussion for that. Someone knows about it. And now we go for, so now you have to, manage this patient very well up to term or maybe salvageability. And now you want to deliver her. You don't want to take her to 41 weeks where you have a fear that you may lose the baby. So how do you plan for the delivery? Whether the patient is on insulin, suppose. So whether now she is in labor, say she is in labor. So whether you give the dose of insulin, how do you manage the insulin dosages?
Night dose may be given, night dose should be given, but morning dose should be skipped.
Yeah.
And in morning, glucose monitoring should be done. And if it is 90 to 120, we don't need to add insulin. If it is 120 to 140, then 4 units should be added in 100 ml per hour saline drip, and 140 to 180, if it is, then 6 units should be given. If it is more than 180, then we can go for 8 units.
How frequently you should monitor the blood sugar levels?
Blood sugar levels should be monitored every hour there in labor room.
Yes.
And according to that, we can manage insulin dosing.
It should not go below 105. Okay.
Yes, ma'am. If it is there, then we should stop
and
insulin.
plenty, and you have to keep the patient well hydrated, because that is what is the protection from diabetic ketoacidosis.
Yes, ma'am.
Postpartum follow-up, definitely, Suman, if you want to talk on this.
Yeah, madam. Yes. Generally, this gestational diabetes seems to get controlled after the delivery. But we have to tell patient that she should continue on the medical nutrition therapy which she was taking earlier, and she should try to reduce, keep her weight under control, and we should definitely do a test of blood sugar after 6 weeks postpartum, and if we see that the blood sugar level is under control, that is fasting is less than 95 and PP is less than 120, then she can, because she has the risk of being diabetic later on, so she should continue to check her blood sugar every year if possible. Yes.
Yeah, I would. Yeah, very nicely said. I would ask all the panelists to take up one point, whether breastfeeding, Dr. Samarina, should we continue breastfeeding? What are the advantages for this lady especially?
She can continue with breastfeeding, ma'am, because in fact it will be a good practice for her glucose control, and also it will cause her uterus to involute at a suitable rate, and as in breastfeeding there will be good maternal fetal bonding. So I think breastfeeding is recommended.
And as far as the diabetes is concerned, definitely breastfeeding has got lots and lots of advantages to the mother, to the baby. But here what we are talking is the calorie lose. She loses almost 500 kilocalories per day by breastfeeding, and that helps in controlling her weight as well in puerperium. So that is very, very important. Any comment on the contraception?
Yes, madam.
Yes, madam. Barrier and or progestogen only pills. I think it will be a better alternative.
No.
No.
Yeah. So hormones, see, definitely you have this medical eligibility criteria. So first one to be most preferred will be a contraceptive intrauterine device. Okay. So there should be absolutely no effect on the diabetes. And then of course, then you have that will be for the progesterone only pills and the intrauterine device. Okay. So first and foremost will be copper T, that is intrauterine contraceptive device, which should not have any effect on her diabetes status. Okay. So this is how you can see here the copper T has got 1, that is no restriction for the use of this method. And 2 is okay, you can use this, the advantage of using this outweighs that of the disadvantages. 3 is I mean that there are disadvantages, but definitely proven risk outweighs the advantages. And 4 is absolutely unacceptable. That is the combined hormonal contraceptive. Yeah. Okay. So insulin is the preferred treatment for GDM. Metformin should not be used as first line of treatment as of now. But as I have been telling you that there are studies going on, and considering our low resource country like India, I think we have been using metformin day in and day out, and our patients are doing very well. Maybe the medical colleges will have difference of opinion because you have, the infrastructure there, you have the resources there, and definitely you need to hospitalize the patient, so you can do that at your setup. But as a practical guide, I would say that metformin is equally efficacious and cost effective and safe as well. Even the government of India guidelines says that metformin and insulin is equally effective. This is what is just the flow chart. What we have initially said, that once the patient is diagnosed at GDM, put her on MNT for 2 weeks. And if she doesn't respond to this, that means if her blood sugar 2 hours postprandial is more than 120, you start her insulin. So when you start insulin, you do the 7-point or 5-point testing. So anytime your blood sugar level should be less than 95 fasting and less than 120 postprandial. So whatever dose of insulin you are starting, if it remains within this range, that you have to continue and monitor the blood sugar levels every 3rd day once you stabilize the patient. Anytime the fasting blood sugar goes above 95, you have to increase the dose. You have to add 1 dose at the dinner time. And anytime your postprandial, 2 hours postprandial, sugar level goes above 120, you have to add 2 units to the pre-breakfast insulin. So that is what in short, and that is how you have to control this blood sugar levels of this woman. So I would just say that advocacy and adherence to protocols for testing, hyperglycemia and pregnancy, what we have decided is universal testing, that every woman during every pregnancy should be tested. And of course, we have a consensus in India. We are doing 75-gram single step, OGTT. Of course, once diagnosed, the lifestyle modification and diet modification, that is MNT, every woman should receive the practical nutrition counseling. That is because that is the cornerstone of the management. And the woman who is not controlled on MNT should go for medication, may it be metformin or the insulin. So with this, I end my discussion, and I thank all of you for contributing wonderfully to this discussion. And I request all of you to remember me, Dr. Sneha Buyar, as your candidate for FOXI Vice President for the upcoming elections from West Zone. Thank you so much. And once again, I thank all the dignitaries, and especially Usha Madam, Madam Priti Bala Sahai, the President and Secretaries of Ranchi, Dr. Shashipala and Archana, and of course, my dear friend, Dr. Suman, for, having me here. Thank you, the speakers, Dr. Kuldeep Singh and my dear friend, Dr. Girija Wag, for her gracious presence and the excellent talks. Thank you so much.
Thank you so much, ma'am.
Thank you so much.
Thank you, ma'am.
Any comments by anybody? And of course, some remarks by Usha Madam are welcome. Thank you so much.
Thank you, Sneha.
Thank you, ma'am,
Really
for the
very nice.
wonderful panel. Thank you, AMOGS. Thank you, Archana, for giving us this opportunity. Thank you, Sneha, ma'am. Thank you, Archana.
You all are most welcome.
Thank you, Sneha.
It
Thank
was
you, Sneha, ma'am.
actually
It was
initiated by
wonderful
Sneha ma'am only.
questionnaire and wonderful discussion on GDM. Very favorite topic.
Yes.
Thank you so much,
It
ma'am.
became so clear, right? It was so clear.
Yeah.
It's become so clear.
It's always important to talk about this, GDM.
So, Sneha Madam, we are going to
But
call
one
you.
thing I've noticed that soon after delivery, the blood sugar level decrease very fast.
Yes.
Almost become to normal level.
Yes.
In many patients.
But patients should continue on her drug, and
that's the reason
nutrition treatment should be.
We were discussing that postpartum management, because hurriedly we stopped there. That how you should taper off insulin and only give insulin whenever required, only after the blood sugar levels. That is what usually it comes down to normal. But definitely you have to assess her after 1 day, 3 days, 6 weeks, and of course 6 months. So that is all from my side. Thank you so much.
Thank you.
Thank you.
Thank you, madam, for being there till the end. Thank you so much. Over to you, Archana.
Yeah, so shall I propose the vote of thanks formally? So it is indeed an honor as a Secretary of ROGS to propose the vote of thanks. I would like to thank, first of all, the Chief Guest, Dr. Jaideep Tank, President-elect FOXI, for today's this webinar, and also the guest of honor, Madam, our own Madam, I would say, Dr. Usha Nar, for their pearls of wisdom. And I would like to acknowledge the AMOGS office bearers, Dr. Rajendra Singh Pardesi sir, the President AMOGS, who could not make it today, unfortunately, because of its some commitments. Dr. Sujata Dalvi ma'am, the Secretary of AMOGS, Dr. Nandita Palsetkar ma'am, the immediate past President of AMOGS, Dr. Kiran Kurti sir, the president-elect, and of course, I would also, can I say our own Sneha ma'am, she's so close to us for Ranchi OBGYN Society, the chair of Medical Disorder Committee of AMOGS, and of course, we wholeheartedly support you in your vice presidential candidature for 2024, and we were there for you in 2023 as well. Thanks to all the esteemed speakers for today, Dr. Kuldeep Singh sir, for his elaborate talk on ultrasound. It was so simple to understand the way he demonstrated everything. And of course, Girja ma'am, the vice president-elect, she had a wonderful talk on jaundice and pregnancy, always a difficult topic. And the more you discuss, the better it is. So this topic is also very close to my heart. And of course, thanks to my chairpersons, the chairpersons for today, Dr. Preeti Balas. Hi, ma'am. Of course, ma'am, I could not say that you are newly elected patron of ROGS. You are well known to everybody. So you didn't need that introduction. But anyway, and of course, the other chairperson, Dr. Anjana Jha, and our own Suman Sinha, ma'am. Thank you for being the wonderful chairpersons. And I would also like to thank once again Sneha ma'am for excellently moderating the panel discussion on DDM with very few short cases, giving clear-cut messages. Every case was like very clear in messages. So you had carefully selected all the cases. And of course, thanks to all the wonderful panelists, Dr. Suman Sinha ma'am, Dr. Madhulika Di, Dr. Samarina, Dr. Rupashri, Dr. Meenakshi, and Dr. Kadambani, they accepted my invitation at a single phone call. Thank you for being there with us. Thank you. And last not but least, I would like to thank Dr. Sahiti also.
Yes.
For wonderfully coordinating everything, putting everything in place, the wonderfully placed all the slides.
And so lastly, thank you, Archana, for such a beautiful
Thank you.
One has to give thank you to you also.